Good evening, ladies and gentlemen. It's fantastic to see so many of you here tonight. Thank you all very much for coming. My name's Helen Jackman. I'm Chief Executive of the Macular Disease Society. We're really delighted to be able to put on these events this year. We've worked in partnership with the Royal College of Ophthalmologists, and this is the last of our road trip. I feel like I've been on a sort of rock star tour, not quite as glamorous perhaps, but this is the last of 8 events that we've done around the country. Really part of the Macular Disease Society's 25th anniversary celebrations, marking the 25th anniversary of the organisation, and really part of our commitment to making sure that our members and patients have access to the latest information on macular degeneration and macular disease, and making sure that we're at the forefront of trying to promote the importance of research. So really all part of our commitment to that. I'm going to introduce Professor Harminder. He is the Chair and Professor of Ophthalmology at the University of Nottingham, and he's also the President of the Royal College of Ophthalmologists. And as I said, we've done these events in partnership with the Royal College, and so we're really delighted that he's here just to say a few words of welcome. Thank you.
Thank you, Helen, and ladies and gentlemen, you're all welcome to the Top Doctors event, as you know, to mark the 25th anniversary of the Macular Disease Society. This is the last of the 8 events organized to celebrate this landmark year. The history of ophthalmology records a turning point here in 1949 when the first intraocular lens implant was placed in the human eye. The history of ophthalmology will record the current times as the next significant turning point in ophthalmology when non-destructive treatments for macular degeneration have been used in human eyes. When the UK chapter of that history will be written, the letters of the name of the Macular Disease Society will be written in golden letters, for that is what it has achieved in this short space of time. The foresight and vision of Elizabeth Thomas and others with her, notably Amrish Chopdar and Timothy Fitch, is really reflected in the successes of the Macular Disease Society. You can imagine at that time to formulate an organization and later a society which not only deals with the medical aspects of macular degeneration, which is something we doctors are good at and that's about all we do, but to look at the social aspects, the welfare aspects, the counseling, the education, the funding, to include people with the disease as part of its membership, as most important part of its membership, and to recognize scientific, technical, and research aspects of macular degeneration as being equally important. I think that is something really commendable. In a meeting not very long ago, I was asked to talk on history of ophthalmology, and I used these words as it's a phrase I coined, which is really stating the obvious, that today is the yesterday of tomorrow. What is today's state of the art may tomorrow be relegated to the dustbin of progress. Research underpins everything we do, and there are very few people who give it its due importance. The Macular Disease Society has done that. They've raised £1.5 million in the last 10 years to fund research, to answer those questions that need answering, and to take us forward, because there are still 500,000 people blind or visually impaired with macular degeneration. It accounts to 50% of the visually impaired people in the United Kingdom. So there's a lot of work to be done, and even though we have these great treatments at the moment, accessibility and the ability to take that treatment to everybody who needs it is the big challenge. And the Macular Disease Society, through its innovation, through its efforts, through its lobbying, is working in that direction, and I'm really pleased to note that we are achieving successes. NICE is listening, and other departmental organizations are listening. So again, another big feather in the cap of the Macular Disease Society. The Royal College of Ophthalmologists is privileged to be associated with the Macular Disease Society, and it cherishes this association. We are 1 year younger than the Macular Disease Society. For next year, we celebrate our 25th anniversary. I wish you well for the next 25 years and beyond. Thank you.
Thank you very much, Professor Dewar. I'm now going to introduce our next speaker, Mr. Adnan Tufail, who may be known to some of you actually. He's a consultant ophthalmologist at Moorfields, and he's going to talk to us a little bit about the latest in macular services and treatments and start to give us a bit of an overview of some of the emerging research. Thank you.
Thank you very much, Helen. Before I start giving an overview of age-related macular degeneration and new treatments, I'd just like to echo some of Professor Dewar's comments and the tremendous impact the Macular Disease Society has made in the last 25 years. As a physician involved in my day-to-day life in treating and researching macular disease, the Macular Disease Society has made a tremendous impact both in supporting individual patients, facilitating research, and lobbying appropriately to make these wonderful new treatments available incredibly widely. And patients in the UK have some of the widest access to treatments now anywhere in the world. And I think that's largely attributable to the Macular Disease Society and other groups. So I've been given a remit to talk about new treatments for age-related macular degeneration. And before I go into that, I'd just like to recap a little bit more about what's going in the eye and clarify some definitions I'm going to be using during my talk. It may be a little repetitive for some of you, but I think it's important to put the context first. So if we think of the eye like a camera, a camera in the eye has a lens and it has a film. And the film of the eye is called the retina, but there's a little bit of a difference between the film of a camera and the retina. In the film of a camera, if we look at the edge of the film or the center of the film, the quality of the image is pretty similar. But the eye is very clever. In the center of the film, there's a specialized area called the retina. And the sensitivity in the center of the film is much higher than in the periphery. And that's because the cells in the center of the macula are specialized and much more closely packed together. So the macula does a lot of the hard work and the fine work for the eye, and it's important for reading and fine vision. And the way that the eye interprets light and turns it into signals we can understand is by a very clever chemical pathway. So light hits cells called photoreceptors, and it causes a chemical reaction that forms an electrical signal that your brain can understand. And like any chemical process, it produces waste. And the eye has to get rid of this waste. And it has a layer of cells under the retina called the retinal pigment epithelium. And they're effectively the maintenance cells or the waste disposal cells of the retina. And they get rid of the waste and look after those photoreceptors and help regenerate chemicals for the photoreceptors. As light hits the back of the eye, it causes all this damage, as well as a byproduct of producing electrical signals. And the eye has evolved a way of repairing itself. Instead of trying to fix the damage from the light all the time, as many other parts of the body do, it's evolved into breaking bits of the photoreceptor off every single day, and those are chewed up by the waste disposal cells, the retinal pigment epithelial cells, and got rid of. And those photoreceptors then regenerate. So there is constant light hitting your macula throughout your life. The tips of those cells are disposed of, engulfed and chewed up by the retinal pigment epithelial cells and got rid of. That's a tremendous load on the macula throughout one's life. It's amazing that the vision stays well for so long in many of us. There are broadly two types of photoreceptors, the rods and the cones. And the cones are important for fine vision and vision in bright light. And they're at the highest density in the macula. But for those to work, you need a functioning pigment cell layer and a functioning blood supply underneath it. So all three layers are needed to produce light. And it's because of this immense workload the macula has to do that it's so vulnerable to disease. of which the commonest disease is age-related macular degeneration. So there are several types of age-related macular degeneration, and people use classifications in different ways. I'm just going to describe the terms I'm going to use. So the underlying process is early age-related macular degeneration, where all this waste build-up overwhelms the cells and waste starts building up. So the waste disposal cells that normally get rid of these damaged cells throughout life get overwhelmed at some time point. They then produce inflammation and waste deposits that are characterized by these yellow deposits the eye doctor can see when they examine the eye, and they're called drusen. And those are the hallmarks of early age-related macular degeneration. With time, and I think the current concept is if we all lived long enough, we all lived to 120, all of us would get age-related macular degeneration, and the waste would build up so much that the tissue would just wear out. And that process of waste build-up to the tissue wearing out is the underlying process of age-related macular degeneration. And eventually you get the late dry form or atrophic or geographic atrophy. So those are synonymous terms, atrophic and geographic atrophy and late dry age-related macular degeneration. And those terms are used in different literature, and that's why it's slightly confusing. So I'm just going to recap. Early age-related macular degeneration, waste builds up under the macula, and with time, that causes the tissue just to wear out. It overwhelms the cells and they wear out. Now, in some patients who have age-related macular degeneration, a second event occurs. And that's when the chronic inflammation triggers the sudden growth of blood vessels. And that's an acute event complicating the underlying process. And what the eye is trying to do is heal itself. If you cut the back of your hand, you get bleeding. And if you do nothing, the blood goes away, but you're left with a scar. And the reason you're left with a scar is because blood vessels grow, have factors in it that cause scar tissue. So what's happening in wet macular degeneration is the same process. It's the eye trying to heal itself, but what that final trigger factor is to cause blood vessels to grow, we don't know. So that's the process. Early age-related macular degeneration eventually becomes atrophic in all of us, but in some of us, a second event occurs and complicates the process where blood vessels grow. So what are the risk factors for age-related macular degeneration? As the name suggests, age is the biggest risk factor. And as the incidence and the prevalence of age-related macular degeneration increases with age. So about 1 in 5 of us over 90 will have the late dry form of age-related macular degeneration. And the underlying biology of aging plays a considerable part in this process. The waste disposal cells are not as efficient at getting rid of waste or getting rid of oxidative damage as they get older. Other consistent risk factors in all studies are cigarette smoking, and also in the last 10 years we're now very well aware of genetic factors being important. And there are 3 main factors involved, genetic factors involved. The main one is in something called our innate immune system. So we all have a defense system, and there is an adaptive immune system and an innate immune system. An adaptive immune system is what vaccination is based on. You're given, in the old days, cowpox, and then your body recognizes the cowpox and then protects yourself against smallpox in the future. So it memorizes something and then it produces a very good reaction when it's exposed to that stimulus again. However, we as humans get exposed to new stimuli all the time, and we must have a defense system to defend against new invaders, and that's what's called the innate immune system. And a variation in our own defense system called factor H is a risk factor for age-related macular degeneration. It doubles or triples your chance of getting it. However, it doesn't guarantee that you will get it if you have that genetic change. And there's a lot of work going on that area. Additional risk factors that have now been found, genetic risk factors, are in fat metabolism and in oxidative stress. So understanding the genetics has been a major advance, and numerous universities and research organizations and pharmaceutical companies are looking in the genetics to develop new treatments. All other risk factors are pretty inconsistent, so the real key risk factors are age, smoking, and genetic factors. So I'm going to address the various forms of age-related macular degeneration, briefly mention where we are, and say what's going on in current research. So wet macular degeneration is something we're now starting to have some very good treatments for. As Professor Dua mentioned, the injections of anti-VEGF agents, Lucentis in the eye, have transformed the outlook of patients with wet macular degeneration. However, as good as they are, they're not a perfect solution. Only about a third of patients that initiate the therapy recover some of their lost vision, and with time, after 6 or 7 years, the underlying process of dry macular degeneration is still ongoing. And we're now starting to realize 5, 7 years down the line, patients are starting to get the worn-out damage. You prevent them losing vision from the wet, but the advanced dry then kicks in. So there's still a lot of work to do. What's just around the corner in the treatment of wet macular degeneration? Well, there are newer drugs about to be approved in the UK, one of which is a drug called VEGF trap, that potentially will last a bit longer than Lucentis. That's a new licensed drug. That's already been licensed in North America, is about to be licensed in Australia, and will probably get licensed here at the end of this year. So this will give us another licensed option which will have a potential benefit for all of us. Now, the big problem with these drugs is delivering the therapy. For those of you in the audience who are under treatment with the Lucentis, you know that it's a tremendous burden for you to come every month or 6 weeks or so to get the injection. Every injection has a small risk. So there is a tremendous amount of work with a number of pharmaceutical companies to get longer-acting drugs that last 4 or 6 months. We also need to know how we optimize the drugs that we are currently using. And we've just finished the first major survey of how the drug is given in the UK. With a very clever electronic record system, we've pulled the information of over 100,000 Lucentis injections. And we're now modeling the data to see how effective we are at giving this drug in real life and how we can optimize our current therapy maximally. And the data of that will be out shortly. And that's really to maximize what we currently have. There are a lot of other drugs in earlier stage clinical trials that inhibit the innate immune system variant, the complement system, and attack or block other parts of the pathway that tells blood vessels to grow and leak and form scar tissue. So drug companies are now looking at combining Lucentis with other potential drugs to try and get even better outcomes than the current treatment we have. One of those approaches has been to combine the treatment with radiation to try and reduce the number of injections. The early trial results have been variable. One approach has shown a slight reduction in injections, another trial has shown a negative result. There is further ongoing work to be done with radiation, but so far it's not been a definitive result so far. Clearly, preventing wet macular degeneration would be better. As I've said, even when we start treatment with Lucentis promptly, we can only recover vision in about a third of patients. And in patients who develop wet in one eye, it's very important to try and reduce the risk of developing wet in the other eye. And the use of high-dose antioxidant vitamins, as shown in the American age-related eye disease study of a very particular high-dose vitamin and mineral combination, reduces your risk of developing wet in your fellow eye if you have wet in your first eye by about a quarter. What has been problematic is these vitamins are licensed as a food supplement, and therefore it's very difficult to get these prescribed on the NHS, and it's something that I've been trying to get my public health colleagues interested in, but so far it's been problematic. The US government body, the National Eye Institute, are doing a second trial called the AREDS-2 trial, where they're looking at lutein and different doses of vitamins to see if we can get even better preventative results. So that's where we are with wet macular degeneration. What about the advanced dry macular degeneration or geographic atrophy? Unfortunately, we have no proven licensed treatment for the advanced dry age-related macular degeneration. So just to recap, this is the net result of the underlying process, the waste buildup which eventually causes worn-out tissue. And as eye doctors, when we look at the eye, we see multiple worn-out patches that look like countries on an atlas, hence the term geographic atrophy. And these worn-out patches gradually enlarge and very slowly over time hit the center of the macula and drop vision. But before they hit the center of the macula, they affect your ability to see in dim light, they affect your ability to read, even though you can read to the bottom of the chart on the vision chart. And it's often very difficult for the optician to understand the visual problems that patients have with geographic atrophy because of these other subtle problems. So one of the things, this is my main focus of research, is treating the dry age-related macular degeneration. So the first part of that is working out very clever ways of measuring change so we can do clinical trials in a much shorter period of time than we would otherwise. Currently, to look at vision on a chart as a trial measure for geographic atrophy would take us a 3-year trial. With potential new measures, we could potentially get proof of concept trial results in 6 to 12 months. And so it's very important we get better measures, and that's something we're working very hard on. So when we approach trying to treat the advanced dry macular degeneration, there are 3 broad approaches. One, trying to stop the waste buildup damaging those cells. The other approaches are to try and preserve the cells from dying from the waste buildup. And the last approach is replacing the cells that have died. So I'm going to go through each of those broad approaches. So trying to stop the waste buildup. So the ways are to try and stop the cells that are shed every day and that are overwhelming the pigment cells, the waste disposal cells, from damaging those cells. And there are chemicals that are particularly toxic that are killing those cells, and this is something called A2E. There are proof of concept studies that if we slow down the production of A2E, we may be able to preserve the cell loss. There's a trial of a cancer drug called fenretinide that has shown that it can slow down, in principle, the progression of geographic atrophy. But unfortunately, it does that by slowing down the chemical pathway that turns light into electrical signals. So although it slows down the death of the cells, it slows down your vision. So it's a trade-off. It's rather like driving your car at 2 miles an hour and not having your engine wear out. That's fine, but you're driving at 2 miles an hour, and that's the problem. So it's a great proof of concept study that potentially this is a good approach, but it's not very good for the patient because they lose their night vision. There's a group I'm working with in Boston where we've got potentially a way of blocking the A2E buildup without affecting the visual cycle. This is in very early stage, and this is something we hope to evolve over the next few years. People have also looked at blocking the complement, the innate immune system damage, antioxidants, and all of those approaches are in early stage clinical trials. Unfortunately, all the clinical trials on those approaches to date have been negative. There has been an initial trial of a drug called eculizumab to try and treat dry age-related macular degeneration, and that has not had a positive result. But there are other pharmaceutical companies looking at other complement inhibitors that may fare better. So the next approach is we can't stop the waste buildup, but can we stop the cells from dying? And there's a whole group of drugs called neuroprotection drugs that non-specifically keep your cells alive for a bit longer. And there are drugs called CNTF and other factors that try and protect that. They're in early stage clinical trials. Another large trial by Alcon, a pharmaceutical company, using a particular chemical to try and preserve the cells, was a very large trial, so over 1,000 patients, was unfortunately negative. So there's been a huge amount of work going into this. It's not that people are not investing time and effort, it's just a harder a problem to crack than wet age-related macular degeneration. So I've said the third approach for advanced dry age-related macular degeneration is to replace the cells when you've lost them. And this is a stem cell approach. And Professor Bainbridge is going to address that in his talk, so I'm not going to dwell on that now. So I've talked about wet macular degeneration, I've talked about the advanced dry. The hope for the future is actually to prevent visual loss occurring in the first place. But in order to do that, we'd have to treat much earlier, when you have the early dry form. When we look at the eye and we just see the bit of waste build-up. Now, that needs to have a treatment that's very safe, that we can use for years. As most patients who have early dry macular degeneration never get visual loss. And the only things that have shown to be effective at that stage are probably stopping smoking. The vitamins, the high-dose vitamins, are not particularly effective at that stage, but the AREDS-2 trial, this new, much larger American study, may show better role for that. The other dietary things like eating more than 2 portions of fatty fish a week and eating lots of green leafy vegetables may be protective. Again, there are suggestions they may. They're good for you anyway, so no harm in taking them. But we're waiting for better definitive trials, which will be out in 2 years from my American colleagues. So in terms of early age-related macular degeneration, we hope we will get there soon. The drugs that I'm working on to prevent the waste build-up may be applicable to treat early. We'll have to wait and see. Now, there are still a large number of patients where none of the treatments we currently have are effective, and they have lost central vision in both eyes. And visual rehabilitation research is very important. There are better visual aids being developed, and the importance of visual rehabilitation and exploring the role of eccentric vision training is still being understood better. A study I was involved in looked at how the cortex, the bit of the brain, may adapt to visual loss to see whether we can train that better. And that work is ongoing. Now, when you've lost central vision, normal telescopes may be supplanted by implantable miniature telescopes. Now, in patients who've got cataracts, there's a potential to take the cataract out and put a little telescope in. Now, the problem with this area is there's a lot of telescopes in general use that have not gone through proper trials, and we are not sure if they are better than just reading glasses. There is one telescope called an implantable miniature telescope that's gone through a formal trial and has just been approved by the US government. This device is put in one eye and magnifies things about 3 times. Now, the advantage of that is things look a lot bigger when you've lost your central vision to use your side vision, but the disadvantage is it makes you lose your side vision. So you can only put it in one eye. If you put it in both, you'd lose your side vision. And the problem of things looking bigger in one eye than the other is your brain may not like the difference if things look 3 times bigger in one eye than the other. And so you have to be very selective in which patients undergo this procedure. And so when we were involved in this trial at Moorfields, we had an extensive period of patient selection with a simulator, and their patients need rehabilitation afterwards. Those devices potentially will be available in the UK shortly. We don't know how they're going to be funded, and it's very important when we do get them that the whole patient selection and rehabilitation process is made part of the delivery of that care. In terms of artificial retina implants, there's a lot in the press about bionic eyes. Now, these are very exciting technologies that are real. However, the current technology is quite crude. And the level of vision with the current chips, one of which is licensed for use in the UK now, is really crude vision. And a patient with advanced macular degeneration in both eyes still has considerably better vision than the current generation of artificial retina implants. They are of applicability to patients who've lost virtually all their vision from retinal dystrophies, where they can barely see light or dark. Undoubtedly, that technology will improve, and undoubtedly they may have a role in the future in patients with age-related macular degeneration as well. What we're now starting to see is new problems with patients with age-related macular degeneration, patients who have stopped getting severe visual loss from their wet macular degeneration are often left with residual distortion, where they can read quite well down a chart, but things look wavy, and they can't read very fluently. And work that we're doing with Steve Dakin at the Institute of Ophthalmology and Pete Becks in Boston is a way of using a computer system to correct back the distortion. It's a bit like noise-cancelling headphones on an airplane. What noise-cancelling headphones do is invert the background noise and correct the noise. And what we're trying to do in a computer system is back correct your distortion. So on a computer screen, we can try and individually tailor to correct a patient's distortion. This is ongoing work, and we will probably be asking for volunteers in the future to try and participate and help perfect that. So in summary, there's a lot of work going on to really improve the delivery of our current treatments for wet macular degeneration, improve the drug we already have, and have drugs that last longer, that are just much more patient-friendly and deliverable. The focus of the research of many universities and the pharmaceutical companies and myself is to treat the advanced dry. We haven't got there yet, but we are getting there, and I think in the next 5 years, I think we will have an answer. So I think we've made huge bounds in the treatment of wet macular degeneration. I think the one thing that is predictable is we don't know what is going to happen in the next 5 years. None of us 10 years ago would have predicted the existence of Lucentis or the genetic advances. And when I talked to Dr. Chopdar, who was one of the founding people who instigated the Macular Disease Society 25 years ago, I'm going to probably misquote him now. He mentioned that a patient asked him 25 years ago about what goes on with age-related macular degeneration. Is there a treatment? He says, we don't know, we don't have a treatment, and there's a lot of work to do. Well, we do have some treatments. We now know what's going on and some of the key factors, and I think these are going to turn into new and more exciting treatments. There's a lot to cover here, and I think 25 years ago, this talk would have lasted 5 minutes. I can't cover everything that's going on in age-related macular degeneration in half an hour, and I'm going to curtail my talk here and try and answer questions. Thank you for your attention.
The third speaker of the day was Professor James Bainbridge of Moorfields Eye Hospital. Professor Bainbridge discussed the prospects of stem cell therapy and provided information on genetics.
It's a real privilege to be here talking to you today. I'm really pleased to be able to have the opportunity to discuss with you some of the progress that's been made over the last few years in the fields of cell therapy and also gene therapy. Adnan spoke very articulately and in some depth about age-related macular degeneration. I know AMD is, of course, by far the biggest cause of macular degeneration, but I know there are some people in this audience who also have a juvenile onset disease, and I intend to address both groups of diseases, not least because the juvenile kinds of disease may respond to different interventions than those that may be relevant for AMD. As Helen said, I work at UCL, University College London, as a researcher, as a scientist, and also at Moorfields, and there I work as a surgeon, a retinal surgeon. And I feel very lucky to be working in these areas at a time when there's been such amazing progress in the fields of gene and stem cell therapy. So, as Adnan said, our ability to see depends principally on the perception of light, and this is a function which is performed by a key cell in the eye, a photoreceptor, and that just means a light receptor. The cell, as many of you will know, is a fundamental building block of our bodies. It's a functional structural unit that makes up our tissues and our organs and our bodies. And cells come in all sorts of different kinds. They can be very specialised, and the photoreceptor cell is a highly specialised cell that's highly developed to be able to detect light at really very low levels and to be able to amplify that signal, as has been described, using a very elaborate chemical reaction that then initiates a electrical signal, just like a signal going down a cable, electrical signal. And that's perceived by our brain and interpreted as vision. So, but because this pathway in the photoreceptor is so very powerful and complicated, with very complicated amplification processes, it's quite vulnerable to a number of different insults, if you like. And the development of these cells, their function and their survival depends on a number of key aspects. And these are both inherited and they are environmental. So the cells depend on a continuous supply of information for their development, their survival, and their function. And this information comes in the form of genes. So genes are lengths of DNA, which, many of you will know, encode information in a language called DNA. And this DNA is equivalent, if you like, to a blueprint or the instructions for building a cell, or indeed to the software that might run a computer program, as opposed to the cell, which is a bit like the nuts and bolts of a machine or the hardware of a computer. So, in fact, the whole set of instructions that's required for any cell is present in any single cell, but depending on what it needs, depending on its specialization, a cell will only draw on a subset of those instructions, a small number of those instructions, to do what it needs. So, in addition to the instructions that a cell normally needs, it's also under the influence of environmental factors. And these include a lifetime of exposure to light, and that can be detrimental, as well as other insults such as smoking and potentially other dietary influences. And this is why, as Adnan said, the photoreceptor and indeed other cells in the retina are so vulnerable to a lifetime of light exposure. So, because the photoreceptor cell has such a complex series of chemical reactions, it's particularly vulnerable to the impact of either gene defects, that's mistakes in the blueprint, if you like, or indeed to a lifetime of exposure to these environmental insults. But to start with gene defects, these are essentially spelling mistakes in the gene. And so some people fail to inherit a whole normal complement of genes, which is required. And should they fail to inherit that, that can lead to abnormal development of a cell, photoreceptor cell, can lead to abnormal function of the cell, or it can lead to accelerated degeneration. And it's these things. So some of the genes are so important that even a single spelling mistake in these genes can result in a profound impact on the functional survival of a cell. And it's these gene defects that can result in inherited diseases and early onset macular degeneration. If we fail to inherit a normal copy of a gene, then that's typically inherited recessively, and that means that our parents typically are not affected, but we may fail to inherit one of the two copies of the gene that we need from either of them. And if we fail to inherit a working copy from either of them, then we actually can develop a problem and lose vision. Where there's a lack of a gene function, one can imagine that it might be possible to actually compensate for that by delivering a normal copy of the gene to the cell that needs it, and that's gene therapy, and I'll come on to that in just a moment. There are other forms of gene defect that might result not in the absence of a function, but in the misinformation that leads to the accumulation of a poison, perhaps, or a toxic byproduct in the eye. And this is another inherited form of disease, but it's typically inherited dominantly, and that essentially means that people who inherit only a single copy of the gene can be affected. In this situation, it's a bit more difficult to treat it because it's not sufficient simply to provide a normal copy of the gene, but it's necessary to actually suppress the expression of the toxic gene. And for technical reasons, that's a little bit more challenging than the alternative, which is simply supplying a normal copy of the gene. Now, we've been doing quite a lot of work on gene therapy for a number of different conditions, and in particular we're interested in conditions which are severe and of early onset. And the reason for that is because we want to get a quick answer to our questions, and we want to minimize the risk of adverse effects in people, because there's a relatively invasive, relatively high-risk procedure. And we've been doing some work in some clinical trials in a condition which affects children, causes blindness in children, and it's a condition that's called Leber congenital amaurosis. It's a condition in which children lack night vision and progressively lose all vision over the course of their first decade or two of life. And the reason that they lose vision is because they fail to inherit from their parents a gene that is responsible for one of the key features of light perception. And we've shown that by providing these children with a working copy of the gene, by an operation to inject that gene into the retina, we can actually improve some aspects of their night vision. And we're very excited about that because it, if you like, it proves the principle for this approach and suggests that a similar approach might be applicable to other conditions, those that involve children and possibly those that involve adults. However, it's important to understand the potential, well, the limitations of gene therapy, and it's only possible, you can only imagine a gene therapy working if you're replacing a single gene that's well defined and a single gene that's at fault, and that there's a surviving cell in which to implant it. In those conditions where there is established cell loss, cell degeneration, then you can imagine that providing the gene, providing the information is not going to be sufficient to improve sight or to protect against sight loss, because the information is of no use to a cell that's not there. So where the cell has already degenerated, we're looking at alternative ways to proceed. And this brings us on to the subject of the subject of cell therapy. Now, the donor cells for cell transplantation therapy may be harvested from a whole range of different sources. They may potentially be harvested from the same individual, or they may be donated by a different individual. Clearly, the potential advantage of a cell being used from the same individual is that it may not be so vulnerable to rejection. And that's something that might otherwise limit the impact of cells which have been transplanted from other individuals. There are a number of different potential sources of stem cells, and they may be derived from very early embryos, or they may be actually derived from little locations in the body that have been identified that also appear to harbour stem cells. Now, it's worth at this point just pausing to try and explain the difference between a cell and a stem cell. So cells, as I mentioned before, are building blocks that are highly specialised. Stem cells are, if you like, mother cells, or cells just like those in the stem of a plant, that have the potential to grow into all sorts of different specialised cells. So they're what we call multipotential. And they also have the ability to renew themselves. And these are the two key features of stem cells. So they are present in embryos because they have to be able to generate the different sorts of tissues and organs that we need. And there are also certain sites in the body where they may be present to regenerate certain tissues, even in adults. In fact, this is by no means the first application of stem cells, and stem cell therapy has been in clinical use for many, many years. In fact, it's often used as part of bone marrow replacement surgery, and essentially that is replacement of stem cells of blood in various conditions, including disorders of the blood and other cancers. And of course, as Professor Dewar will know, it's also used, and I'm sure in his practice, in terms of repopulating the surface of the eye. and stem cells are actually present on the surface of the eye, and these can be used to replenish the surface where it might fail otherwise. But what we're trying to do now is to extend this work into the retina, which is a different challenge because these cells are neurons, and typically neurons are much more difficult to encourage to reproliferate and regenerate. And so we're faced with a different set of challenges. However, it's been recently shown that embryonic stem cells, so cells taken from a very early embryo, that is one which is only a few cells big, a little clump of cells, and is actually nothing like what one might imagine to be an embryo, can be grown in the laboratory into cells which are, to all intents and purposes, exactly the same as retinal cells. And this has been very exciting because it offers the possibility of generating cells in the laboratory that might then be implanted into the eyes of people with degeneration, and that includes macular degeneration. Now, just to make a distinction again between the different types of cells in the retina, as Adnan explained, one of the key cells is the photoreceptor, that's the light-sensitive cell. And in addition to that, there are a whole range of cells, but one which is particularly important in macular degenerations is the underlying pigment cell, which is important for support and survival of the photoreceptors, as well as enabling them to function normally. So these are the two key cells, if you like, that we're predominantly interested in because they appear to be at the heart of macular degenerations. Now, it would be very nice to be able to replace photoreceptor cells. And indeed, there is a lot of work going on in the laboratory to do just that. And I work very closely with teams at UCL who are working on that question and have actually shown that in the laboratory it's possible to transplant photoreceptors between one animal and another, one mouse and another, and show that those cells, those photoreceptors, can survive and they can integrate into the retina and they can actually form functional connections with neighbouring cells to the extent that they can mediate responses to light and that they can enable animals that previously were not able to navigate in particularly dark situations. So there's proof of principle already that it may be possible to transplant photoreceptor cells between one individual and another. That's going to be a huge challenge to translate that proof of principle from the laboratory into a treatment that could be of benefit to people with macular degenerations. But that is something that at least we've made an important important progress in. But what appears to be potentially more feasible in the shorter term is transplantation not of photoreceptor cells but of the underlying supporting pigment cells. And I have recently been involved in a trial in which we are beginning to look at the potential of that approach. So what we've been doing is to transplant pigment cells, which have been derived in the laboratory from embryonic stem cells, into people with advanced macular degeneration. This is work that I've been doing in collaboration with a company in America called ACT, and ACT are also doing some other similar trials in the States. This first trial is very much aimed at finding out if the approach is safe and if the cells can survive inside the eye. And for that reason, we are choosing people in the first instance who already have advanced sight loss so as to minimize the impact of any harm that might come as a result of the surgery involved or indeed as a result of the cells being there. You can imagine that there are a number of risks involved in this kind of surgery. There are risks involved in terms of manipulating the retina, and the cells themselves are at risk of generating inflammation, immune responses in the eye that might be harmful. And indeed, because they're derived from stem cells which are, have been proliferating, there's also the risk of causing tumours or cancers inside the eye. And so we're predominantly interested in this stage in answering the question about whether they are safe and whether they can survive. The survival in the eye may be dependent on the use of quite strong immunosuppressant medication, the kind of powerful drugs that are used for people with kidney transplants and heart transplants. And the question is whether these drugs, which can have their own set of side effects, are justified, and whether we can ultimately show that the level of benefit in terms of visual improvement is sufficient to justify any long-term risks of these quite powerful and potentially harmful medications. It's possible that the cells might survive in the eye regardless, even without such medications, because the eye is relatively protected from the immune system, unlike other organs. And so that's one of the many advantages of using the eye for this kind of work. For this particular trial, what we're doing is giving people immunosuppressant medication for a period before and after the operation, and then withdrawing it. And we're looking very carefully to see whether the survival of the cells depends on the presence of the continued supply, rather, of the immunosuppressive medication. So in this particular trial, what we're doing is injecting a suspension of the cells, and that means essentially a mixture of the cells in water, and seeing if we inject them under the retina, whether they can form a layer of cells that is appropriately organised to do some of the jobs that the worn-out cells would otherwise have done. But there are alternative approaches to this, and I'm very interested to learn that you will be have the benefit of hearing from Professor Pete Coffey at one of your next meetings, because he is pursuing a similar approach, but with some important differences. And he's using stem cells to generate pigment cells in the laboratory, and then not injecting a mixture of cells in fluid, but actually implanting a layer of the cells underneath the retina. And this has potential advantages because it will help ensure that the cells are appropriately organised, but there may be some disadvantages because it may be a more complicated surgical procedure, and we have yet to find out whether the substrate, that's the layer that the cells are mounted on, will be tolerated in the eye. But as I understand it, it does appear to be tolerated in experimental models in the laboratory, so it'll be very exciting to see whether this can be of benefit. Another key difference between our two approaches is that for my work with the ACT company is directed solely at people with juvenile macular degeneration, Stargardt disease, whereas Pete Coffey's work with Lyndon de Cruz will be targeting people with forms of age-related macular degeneration, AMD. Ultimately, in many forms of macular degeneration, the degeneration of RPE cells, of pigment cells, goes hand in hand with degeneration of photoreceptor cells. And the ultimate solution in terms of cell replacement may involve combined replacement not only of pigment cells but also photoreceptor cells. And that's something that we would like to, well, we hope that might be possible in the future. But there are a number of major challenges that we're addressing in order to get to that stage. It's something we are working hard at doing. Adnan has already talked about pharmacological therapies and electronic retina, the bionic eye, so I don't propose to discuss that in any more depth. But what I would like to just say is to explain how we're going about addressing these problems by setting up a program of research, and that includes a number of experimental models in the laboratory to study mechanisms of disease so we can try and understand exactly what's going wrong in these conditions that we've been talking about. We can then begin to develop and design new treatments, new interventions. And this involves both gene therapy in particular conditions that might benefit from that, where there's still surviving cells, but also cell therapy for conditions in which there is early or advanced cell loss. And we're devising the program according to very carefully selected conditions so that we can try and accelerate the progress by designing trials that will be able to answer very specific questions about the safety and the potential benefit of these approaches. So we're not necessarily choosing the commonest conditions in the first instance, but we're choosing conditions in which we think we can get clear, rapid answers to the scientific questions we're asking, so that we can make rapid progress towards the common blinding conditions. So we have a pipeline of clinical trials for gene therapy, which typically involve children or early onset conditions. And we also have beginning to look at cell transplantation therapy with the trial I've been talking about and the experimental work in the laboratory. And to do this, it needs a huge infrastructure of people that involves not only scientists and clinicians, but also technicians, nursing staff, coordinators, and we're also very fortunate to have an international group of collaborators, all of whom bring complementary expertise to what is essentially a global enterprise. We're very fortunate at Moorfields and at UCL to have funding from the government in the form of the National Institute for Health Research, and we are fortunate to we're very fortunate to convince the government that we are very well placed to pursue this kind of work, and they've invested very heavily by giving us the funding for a biomedical research centre, and that amounts to funding of 25 million or so over a period of 5 years. And that has given us a lot of power and ability to be able to put together the kind of resources that we need to do this work. At UCL, we have the ability to generate the gene therapy vectors and potentially to generate, well, as Pete Coffey has shown, actually to generate the cells. And we also have funding from the Special Trustees of Moorfields Eye Hospital, to which we are hugely grateful. And we have been very fortunate and successful in applying to the main government bodies and charities, including the Medical Research Council and the Wellcome Trust. But we're also very dependent on other sources of funding. We've been very lucky to have some funding from RP Fighting Blindness, because that's enabled us to continue the momentum and maintain some highly skilled individuals in our research team. That's otherwise very difficult to do on the basis of funding that's given for specific projects. And with that, I'd like to end, but I'm very grateful for the opportunity to talk about this, and very happy to answer any questions. Thank you.
We've been extremely privileged this evening to have three such eminent experts, Professor Harminder, Professor James Bainbridge and Mr. Adnan Tufail, and I'm sure that you'd want to join me in thanking them. So I just wanted to thank you all really for coming, but also to those of you that are members of the Society, to thank you so much for your support. Your membership of the organisation not only gives us a voice and enables us to speak on behalf of people with all sorts of different macular conditions, but your support enables us to invest in the research. We may only invest in fairly small early stage projects, but that work is really, really important, and so your membership support is hugely important. It also enables us to provide the services, our helpline, our counselling service, and our local groups that are so important to people. So thank you for your membership, and we hope that perhaps we might see some of you at our September conference. Thank you and have a safe journey.